Welcome to you all about this series of paraprosthetic joint infection that is represented by Dr. Mahmood Shihab. He's a pioneer in the knee surgery in Medical City Complex. You have the mic, sir, and thank you very much for sharing these ideas.
Thank you very much, Dr. Sinan, for this nice evening. And I will continue for the series of very important subjects regarding the PJI and SSI and how you deal with these cases when you are doing the surgery and what's the way to prevent the infection. Always we say prevent is better than treatment. So just I get some review for this not attained the last lectures, what we have talked about, how you get prevention of the PJI and SSI and safely you are doing the surgery, and what measures we talked about that's it's mandatory. We talked about the factors that affect the biofilm regarding the host factors and bacterial factors. In host factor, we talk about the importance of screening of the nasal swab and importance that the drugs which must be stopped, anticoagulant, steroid, anti-rheumatoid. And we talk about the diseases that must be controlled prior to the surgery regarding the anemia, diabetic mellitus, and other chronic diseases, and how we prepare the skin before the surgery. Then we go further over the prevention regarding the antibiotic, and we talk everything regarding the duration, where you preoperatively before half and to 1 hour prior the surgery. And if you have allergy, what is your plan to change the antibiotic? And what is the talked about the risk regarding the patient and in the revision cases. And also we talked about the important subjects, which is the biofilm, and it's significant in causing of the PJI. And we talked about the detail of mechanism of formation of the biofilm formation. So we talked about these things, and we say that everyone will get this complication during his surgery, and you face it in outpatient and or in your practice, that the patient will present you like this picture: sinus, abscess, wound discharge, implant outside, and every aspect of the PJI or SSI. And we talked that whereas we surgeon, we may face these things and not get outside of the this field, and we must face it and open the window and deal it. And whenever you feel it's difficult, you can refer to special center. Always we talked about the plan, and in the plan to get the safe, you check the tire, you check the station, and during your TKR, always you plan that your surgery will end without this complication. So complication less, morbidity and less mortality. Regarding some point about the biofilm, how it forms, regarding his from the attachment, aggregation, and his formation, that it is special mechanism by steps. When it's attached, then adhesed and aggregation, then disperse, that's separated from the foreign body and causes more infection. Biofilm is important, and we talked in detail about that condition. Why it is important in arthroplasty? Because it adheres to the foreign body, because we are using a lot of foreign body implant, prosthesis, plates. That's why biofilm, when it stick to this foreign body, will cause foreign body infection by the bacteria which is hidden under the biofilm. The treatment is always surgical, assisted by the antibiotic, which is diagnosed germ and sensitivity. But when there is biofilm, the treatment is mandatory, is surgical. And we get summary from the previous lecture that no biofilm without bacterial colonization. If you have biofilm, this means you have colonization of the bacteria. And we keep in the mind that biofilm may present in the river, in the stone, everywhere. So it is common style and in the nature. And we talk, they say, they colonize by quorum sensation, by formed by the villi, pile, and electric conduction by protein. And when there is biofilm, we talk that it will need surgical therapy. What's ideas? We talk about the prevention to communication and provide this quorum sensation. We talk about the many ideas. One of them is the antibodies and vaccination, but it is not viable till now. We talk about what's about chemical approach, but some of them is toxic and without benefit. So biofilm, we talk that when there is, the treatment is surgical. So to prevent biofilm formation, we are talking in all our series to prevent this biofilm formation and bacteria, to deal with the bacteria. So we have surgery without any infection. And we talked also about the intraoperative antibacterial measure regarding the washing solution. And we say in a CDC or international consensus meeting, they advised or recommend application 1 day before the antiseptic. And we talked about the irrigation with betadine, 17 cc with 500 saline for the irrigation, at least 2 times 4 to 9 liter. And we talk about the antibiotic loaded bone cement. Is it make sense to use it? And we also we talked about the phenomena where the antibiotic elution within the first hour or by bulk diffusion, and the surface phenomena. We talked about within 1 hour, the synovial fluid is full of the antibiotics. And we talked also about how mixing it by manual or by the material special vacuum device. The most recommended goal is that antibiotic must be on homogeneous distribution with the powder. And we talk also with the side effect of the antibiotic, which is present, whether ototoxicity or nephrotoxicity. And we get into great detail for the evidence of usage of antibiotic with the bone cement, because some literature say yes, some literature say no. And we talk there is controversial about this condition, and it takes a lot of discussion about voting regarding this point. And in the end, one question is highlighted: is there rule for the use of antibiotic interpregnant cement in primary total joint arthroplasty, whether hip and knee? The recommendation in primary, you may use in primary, you can use without antibiotic or with antibiotic, but the cost, in regarding the cost effective and the side effect of the antibiotic, not to reduce the PJI or SSI. And this has the, I think this from the, this 10 minutes, we talk about the previous lecture, and my colleague Sinan, with a pleasure, they provided in YouTube. Those for the, my colleagues have no chance to attend the lecture, he can see it in YouTube. Now, our today our subject, our lectures, would also to continue with the series of prevention of PJI. We talk about the wound closure and surgical dressing in the joint arthroplasty, how to prevent PJI. I am talking this simple thing that everyone faces in our world, in our theater. It is very simple thing to do it and to put it in your mind that you can do it and you can prevent this infection. So before I am going to wound closure, it is very important to know, get idea about normal phases of normal skin healing. Which start from the hemostasis, inflammatory phase, and proliferative phase, where fibroblast is proliferating, then to remodeling and scar formation, then scar maturation. This 5, why it is important? Because in case of infection, there will be interruption of this phase of healing. The elevation, the inflammatory phase will be prolonged, and we are getting to stay of chronic wound. When there is infection, these steps will be prolonged, that the inflammatory phase will prolong, and we going to state of chronic wound phase, and the fibroblast will never proliferate to go to the scar formation. So for the healing time, it's mandatory to know where every layer, how much time takes to be healed. This is for the every surgeon is a principle, and you must know it. This, it's important that the skin takes from 5 to 7 days, mucosa 5 to 7 days, subcutaneous 14 days, and fascia about 14 days, and bone it takes long time. That's important. That's why we are saying to remove the suture after the suture to be removed after 2 weeks, because subcutaneous layer, it takes this time for healing. Okay, what's the risk factors and non-risk factor for the wound healing and patient risk factor? Obesity is one of them, diabetes, and smoking. That's why for the patient having this risk factor, we can say there will be a long period for healing. You put in your mind that this patient will take long periods before the surgery. What's our rule in closure every layer? What we need when we go to the knee arthroplasty? For the capsule and arthrotomy side, we need first, when suture is very strongly, and we need bioburden reduction that stand all the inflammatory process to get watertight seal. يعني مثل الحنفية اللي مسدودة كلش قوية. For the subcutaneous layer, we need also strength and bioburden reduction. But what's about the skin? We need everything in addition to cosmesis. That you need nice looking, and sometimes we do it subcuticle. What's about the wound perfusion? You must know that whenever there is a good blood perfusion to the area will be a good healing. So if you observe regarding the high percent of the oxygen when there is less oxygen tension, Whenever the oxygen is more in the area, the infection will be less. What's about inflection? We know that there is uneven wound tension inflection. If you look to the proximal part and distal part, P1, which is directly above the patella, suprapatella, have tension more than other site in flexion. So whenever you go high, the tension will be less, especially in flexion. So half of the power when you getting to the flexion, the P1 and D1 stand this power of the tension. You must keep in your mind. That's why these places must be sutured very tightly, that it needs to stand flexion, extension when are you doing the exercise physiotherapy. What's about the suture we are using in the surgery? If you look from the glycolic to the non-absorbable, these areas that the Dixon and non-absorbable, if you look, this they lost their power, but after 6 weeks at least. But the other silks and they lost their power less than that. That's why you must keep in mind what type of suture you are using, because the strength different for this suture to stand the power for long period. Okay, another subject. What's about the continuous versus interrupted? The continuous suture is better prevent fluid migration from inside to outside and even distribution of the tension across the incision, and less time, of course, for us to perform this matter, and less foreign material, there is no knots. What is the against remarks in this, which is compromised, that when there is infection, you must open all of them. In continuous, uninterrupted, that just this condition, when there is infection, you open one suture. What's about the skin incision perfusion, blood distribution? In continuous suture, if you look, it is better perfusion than interrupted suture than skin staple. So this is advantage of continuous versus the interrupted. What's about the staples versus suturing normal suture? There is it is a good number. They say staples has risk of infection in comparison to the silk, but actually in consensus meeting ICM, they say there is no difference in what type of the suture you're using regarding PJI or SSI. But there is another lecture that they're saying that staples, it is like a foreign body may initiate SSI or PJI. What's about those suture which is coated by antimicrobe? Also, there is triclosan suture has reducing. Question 3 was ASM. Do antibacterial coated suture reduce the risk of subsequent surgical site, PJI? And the recommendation, it is the use of the antibacterial coated suture reduce the risk of SSI following surgery. It is colorectal surgery. However, there is no conclusive evidence that it reduces the risk of subsequent. So some says okay, some says no. Even the suture which coated with antibacterial. This is also, the cost effective regarding the companies. And this is another study that using of the suture coated with antimicrobial agent reduce the risk of PJI and SSI. The other material which is start in the market now is present, which is called barbed knotless suture, الشائك المشبك. It has some advantage that it causes watertight closure because it is optimized the wound, there is no knot, and it is very, regarding to the suture or staple, it's fast surgery, and it is barbed, يعني مشبك from everywhere, so provide a good strength and avoid to use the staple, and you can freely use tranexamic acid with no drainage of the fluid outside of the wound. And of course, by this watertight, you can reduce the anticoagulant because it works like a tamponade. There is some research compare the traditional suture with the knotless. The wound leakage, it was 356. For the barbed one, it is about 90. And what's about the bacterial adhesion? It is less in knotless suture in comparison to the vicryl. This means bacteria more easily adheres to the vicryl than the knotless. And also BTS also less. What is the, when we are talking about watertight healing, what you can do for any surgeon? First of all, you can use intravenous tranexamic acid 1 gram with the start of the surgery IV, and you can give 3 gram intra-articular, you inject it, or from the drain, about 3 gram with 35-30 ml saline, and you check the suture, which in watertight there is no leakage. So this is, of course, reduce the hematoma and reduce PJI. The second thing, there is some companies now, there is glue. Glue is not related to the PJI, but it reduces the wound complication. And whenever there is reduction in wound complication, this means reduction of SSI and PJI. And there is also study when you are using glue, the drainage was 153, 155. In comparison to classic suture, it was about 650. And other thing, you can use now occlusive dressing like Comfir or Confitac, or sometime combined with the silver. This is all will reduce the drainage of the wound, and at the same time, it's very easy for watertight the wound healing and safely your wound healing. And we said what's about this new advanced addressing, and I will talk in the second lecture. But one of the questions in ICM, what surgical dressing, occlusive silver impregnated dry gauze is associated with lower surgical site SSI periprosthetic GI infection undergoing orthopedic? The recommendation is occlusive and or silver impregnated dressing have been proven to reduce the rate of SSI and PJI. So there is about 81 consensus about that when you are using this modern dressing, occlusive and sometimes with or not silver impregnated dressing. The other method that you assist your wound healing to reduce the hemoarthrosis in post-operative situation position. You can put it in 70 degree of flexion. Why? Just for 2 hours, not more than that, to reduce hematoma formation. And hematoma formation, as we know, may cause blood transfusion because decrease the blood. And this blood transfusion may be a risk factor, as we talked, for PJI and SSI. So for 2 hours, you can put it to reduce the hematoma and act as tamponade. The other highlight about the section drain, whether to use it or not to use it. Question 5 in ICM, does the use of surgical suction drain increase the risk of subsequent surgical site infection? Recommendation, there is no direct evidence to suggest that use of surgical drain for 48 hours leads to increase the rate of subsequent infection or SSI. But keep in mind, the drain, if you put it directly, open it directly after the surgery, this will act as negative pressure and get the blood from all the area from the knee and vacuum, and maybe drainage of the blood, a lot of amount that cause some source of anemia, more than 1.5 blood. It needs blood transfusion, so you create a risk factor for PJI. There is no evidence that suction drain causes infection, but it's better to put tamponade for 6 hours, not open the drain, because this blood collect and pressure to the small vessels and causes ischemia, and no blood will take in. So you open it after 6 hours and you get a less amount of evacuation of the blood from the wound. And there is also another evidence rule of section drain after knee arthroplasty, even for the using those who's using tourniquet or using tranexamic acid, whether we can use drain or not using the drain. But when there is no drain, keep in mind that you must ligate perfectly all the vessels precisely, that to not miss some of the vessels that cause hematoma. What's about the revision? There is also controversy. One of them, you see in 2016, there's no difference where you put section or not section drain. And some of them, in Ashrafi in 2001, say it's become worse when you put drain. But for my experience, because of the revision, there is a big space, it's better to put the drain. Okay, what's the summary of our first part of the lecture? Healing mind, healing phases, healing time for every layers, and different layer needs with get idea about the different layer and what the different need of each layer regarding the tension and perfusion. Watertight suture with objective, not get drainage from the wound. This is the goal. No drainage from the wound. Whatever you measure intraoperatively regarding the suture, tranexamic acid, management by moderate dressing, not getting drainage from the wound. We will talk in detail in the second part of our lecture. Why? Because we need to avoid hemoarthrosis, which is common, I don't say complication, but common events. Those surgeon using tourniquet or not using drain. So avoid hemoarthrosis, avoid drainage, avoid complication that you give blood and you get a risk factor for PJI. Now we're going toward the second part of the our lecture, which is surgical dressing management in hip and knee arthroplasty. And also, this is our bedbreads daily with surgeon who's working in this subject. What is surgical dressing? Surgical dressing it as a physical barrier during healing it's actually the important time, primary healing, at least 48 hours. This is barrier for the contamination, for the bacteria coming outside and enter the wound. Why? Because there is a strong relation between SSI and PJI. Because when during this 48 hour, when it's happen SSI, that the coming to the subcutaneous tissue, they may cause the PGI. So there is a strong lesion in the one of the we have open marks. ملاحظات مهمة هسه عندنا. Which type of dressing? You are a surgeon and you advise your colleagues, your sister, which type of dressing you must use. How often should be changed? And if there is discharge, what you will do. This is your daily observation for any knee arthroplasty, even the hip arthroplasty. For the first remark, which type of the dressing? Actually, the type of the dressing معلومات هاي انطيكم اياها يعني لانه تتعاملون وياها يوميا حتى تعرفون شنو الدريسنج يسوي شنو الفائده مالته. Type of dressing either passive, which is a protective, or it is active, which it have two aim, protective and there is moist environment, and interactive have an additional job. So the passive like normal goes. Active whereas conceal اعتقد انتم موجوده عندنا شايفين الكونفيل. And interactive vac system اللي احنا عندنا كل واحد يستعمله. So which type of dressing? This is your dressing and this is aim of your dressing. Either protective or protective with moist environment. That's called the good perfusion and good healing. And interactive that you do another action, additional action. This is options regarding the traditional absorbent, it goes, foam, any type of foam we sometimes using in regarding in the war surgery, or hydrophilic hydrocolloid, and some of this using with conceal type sometime when there is drainage more than 3-5 days, we use these the type of the dressing. What's of the objective? شنو صفات dressing you are using or أهدافه? Must be physical barrier for bacteria. This is very important. With at least with the early phase, 48 hours, must be occlusive, occlusing the wound and not causing contamination from the skin to coming to the subcutaneous, because as we say, there is a strong relation between SSI and PJI. So if there's contamination from the skin to subcutaneous, subcutaneous may go to the joint, causing PJI. So must be physical barrier for the bacteria. It provides moist environment. This is also by occlusive, and this is type of the dressing. And you think, is it provide this object هذا الصفات بهم? And fluid management, exudate that the conceal, if you put it in the skin, you see after 2 days, 3 days, there is a lot of the fluid because it's getting outside. It's absorb the fluid. And of course, we must keep in mind it had low dressing exchange frequency. This is very important for us. So we're not going to change the dressing. what's about the lecture بحوث هواية صارت research about classic versus hydrophilic, classics versus the modern one. Of course, the hydrophilic less blister causing and less dressing changes because it may stay 5 days, 7 days, and low rate of skin complication. Of course, its cost is classic is less than the hydrophilic, and there is high patient satisfaction, and of course low PJI rate. Kia research on 875 for classic and 930 acquisal, that is the moderate dressing. Look, the percentage of the PJI dropped from 1 to 2.5 when you are using moderate dressing. For the gross, reducing the percentage of the infection from 1.5 to about less than half. For KIO 2007, reducing the rate of the infection from 8.5 to about 1. For SHIN 2017, also reducing for the rate of the infection. TISOSCO 2017, reducing the PJI superficial infection from 6 to about 4, and PJI from 2.5 to 0. Sherma also 2000, also for modern dressing foams and versus classing, lower rate of wound-related complication, but not conclusive evidence on PJI reduction. Why? Because this dressing is actually reduces the wound complication, and reduction of wound complication directly reduce the indirectly the PJI. There is no direct, we cannot say when there is infection, this is because of the dressing. There is no direct relation, but there is a reduction in wound complication. Yes, there is a reduction in wound complication. Okay, there is some dressing now using silver with it, but they observed it's not superior in ulcers, in diabetic foot, not superior in surgical wounds, and superior or in mixed wounds. And it doesn't matter to make difference regarding healing time, antibiotic usage, pain, satisfaction. So the silver, it is, there is also meta-analysis about the silver versus non-silver coated. There is low quality and insufficient evidence that silver has a role in the reduction of PJI or SSI. And there is question 6 in ICM. What surgical dressing, occlusive, silver impregnated dry gauze, is associated with lower risk of surgical site infection? Pre-prosthetic joint infection, SSI, PJI. And the recommendation was occlusive is preferred, occlusive and silver impregnated dressing. Occlusive is preferred to be used in comparison to other type of classical dressing. The second remarks, how often should be changed? This is very important. The traditional dressing, we know as a surgeon, always we were about the wound. And coming to the ward, second day, third day, try to be near, keep with the wound. The traditional, we want daily wound dressing, and we have internal feeling that taking care of the wound and what is what's the wound to be understand. If something goes wrong, we want to see, remove the dressing to see what's going there. And we want sometime antiseptic betadine application. This is the tradition which used by the surgeon when are doing to hip and knee, that is getting feeling that must be near the wound for checking. So, there is a need for routine wound inspection? This is a very important question. What events you think that you will see in the wound when you are doing total knee replacement or total hip replacement? What event you will see, you feel as a surgeon? Maybe there's erythema, allergy, blistering, or there is discharge, or sometimes superficial infection, and more advanced, there may be necrosis or maceration. For like this picture, you may see post-operatively in the ward. But the important thing is wound discharge, ambati shemis. If it is all of them need for opening, this is the important question when you see the discharge. It's important to get an idea about the type of the discharge and amount of the discharge. This is three pictures to see this amount the discharge, and also the type of the discharge, whether it's yellow, it is synovial or red. This is it's important to care about it. How often should the dressing to be changed? At least we know that primary healing is needs, according to the phases of the healing, 48 hours. For the first 48 hours, it is better not open, keep it dry. So exposure before 48 hours, this causes contamination. This means bacteria coming from the skin to the wound, subcutaneous, going to the joint. It's better to keep it dry for 48 hours. And because the first dressing in the theater, so it's better to be in aseptic condition. In CDC and NICE, they keep according to the protocol for first 48 hours, not change it. What's about international consensus meeting? This question, when should sterile surgical dressing be removed and how frequently should subsequent dressing be changed following orthopedic procedure? If you look under, if possible, never, based on the discharge. If there is no discharge, it's better never to be opened. And this is, for my experience, I opened the wound after 1 week, and then after second week to remove the suture. And the recommendation was, should be changed based on a saturation of the dressing, early removal, and frequent changes of the surgical dressing are not needed. There is consensus about this. Doesn't need early change. 48 hours, if there's something to get more. And if possible, please never open the wound, which is sterile in the theater. Second, how long should be covered? This is sometime, we have a tradition that the water, the soap, it's not going to the wound. There is literature about that, and keep it covered for 48 hours, and after 48 hours, you can uncover the wound. And there's many lectures, showering or not showering, it has no difference in the rate of the infection or wound complication. So another review from the Dighton 2000, showering does not increase infection. يعني حتى المريض يقدر يغسل. For you in 2016, shower 48 hours versus 2 weeks, it's no difference for wound colonization. So it's not affecting PJI or SSI. In ICM, there is question 8. Do patients need to refrain from getting a surgical incision wet or submerging it in water to prevent surgical site infection, periprosthetic PJI? If so, for how long post-operatively? It is keep it dry for 48 hours and then you can showering it. That's why for the first 48 hours, nothing to be changed or no showering. After 48 hours, there is no difference whether you are using or not using regarding rate of infection or SSI. Now, the third remarks. What do in case of discharge? This is important for us when we, in the ward, we come see the discharge from the wound, how we manage. Why thinking about this, why worrying about this? Because wound discharge means incomplete sealing and the risk of bacterial entrance. There is source or in the wound that bacteria may enter through it. There is also sign of possible pathological wound healing. The healing, as we discuss in the phases of the healing, that will be long wound closure, as we said, when there is infection. And when there is excessive humidity, more than what needed, there will be risk of maceration. In wound discharge, what's our goal? What's it need to be care about? Its duration of the discharge and amount of the discharge after post-operative period. So post-operative, the amount and the duration. What is the prolonged discharge definition? It is mean 48 hours, some say post-operative day 3 to 4. There is different definition for this is to say it is prolonged discharge. Maybe beyond post-operative 4 days or several days after surgery. This is prolonged discharge. 2 days post-operative for non-infected and 5 days for the infected. So this is, say, define prolonged discharge. What is copious discharge? This is the first one for the duration, second one for the amount definition. So when we say this copious, you must know what I mean. It's a prolonged, what I mean. Copious, the amount of the drainage is alternatively defined. Drainage has soaked through the post-operative dressing. كل الضماد صار مبلل. Greater than 2 cm by 2 cm area of drainage covering gauze. المساحة. Discharging outside the wound from the gauze. And there is microorganism cultured from the drainage. This is, we say, copious discharge. So there is an international consensus meeting. What is definition? Discharge definition. What is the definition of persistent wound drainage? When you are saying persistent wound drainage, what's the consensus about this or recommendation for this definition? This means discharge beyond 72 hours. When there is discharge from the wound from the beyond 72 hours, this is mean discharge, or this means persistent wound drainage. When there is above 72 hours. Prolonged discharge. Also, there is one question. What are non-surgical strategy and address or draining wound after total joint replacement? Also, 72 hours. Persistent discharge or prolonged discharge, which needs medical action after 72 hours. This means it needs medical action. The important thing that when you see discharge in the wound regarding the soaked, the gauze مبلل, or outside from the wound, 2 things must not be done. First, swab never take from the wound. Second, never give antibiotics. This is recommended for the ICM. What you can do for them, there is something to be as a principle and steps to do. No antibiotic, no swab. When there is discharge within this period, what you will do? First, pharmacological action, try to stop anticoagulants. Mechanical, stop physiotherapy, especially flexion. Regarding the wound, mechanical compression, VAC, you can use it. And if it's continuing discharge, you can go to the surgical DR. These four, according to the amount, according to the period, you can deal with the discharge. Instead of giving antibiotic or swab for culture and sensitivity. First of all, if we, in modern dressing, if there's wound discharge, you get idea about the size. If it is up to 2/3, no need for change of the dressing. This. If it is more than 2/3, there might be risk of maceration, so you get change it. If it is flow, if it is more for long period, you can go to the VAC, negative pressure wound therapy. Negative pressure wound therapy. The advantage of the VAC, because it goes flow outward, absorb the fluid from the wound, and also stimulate granulation. This is what is indication? It's indication for the prophylactic, for high-risk patient, and therapeutic. The literature for the prophylactic use not encouraging and cost-effective because this is primary wound healing. But for therapeutic, for long post-operative drainage, it's advised. But this is also, it needs evidence-based medical action. This is, yes, used for prolonged period, but this is needs evidence-based medic that you depend on it to use the VAC when there is between 5 and 7 days. And this is the literature would show that there is decrease of the SSI and PJI when you are using the VAC. As I said, in our tradition, antibiotic is ineffective and there is false negative. Wound swab, false positive. And keeping in the patient in the hospital without any maneuver, which I say this for action, pharmacological, mechanical, and also not changing and not get your aim to deal or manage with the drainage. As I said, evidence-based medicine, one of the literature showed comparison of the using VAC with the surgery. It is success, it's both of them 76 to reduce the risk of infection. So it will compare VAC to the DIA. This is one of the, actually the literature. As a general, when there is drainage, during hospitalization for 2-3 days, you observe the amount, the drainage, whether less than 2/3 or above 2/3, and accordingly to go to moderate medical dressing and stop anticoagulant, and you can stop the physiotherapy. And if it is continue more, switch to other type of dressing, which is Confil or hydrofiber. So get the oxidate from the wound to get benefit from the staying of the hospitalization. And if it is continue, you can add vac system between 5 to 7 days. And within the vac, you can apply the physiotherapy. If it is after 7 days, there is persistent discharge, you go to DIR. Debridement, antibiotic with the implant rotation. This means poly exchange, synovectomy, lavage, you get intraoperative culture if there is something biofilms to get culture, and antibiotic-based intraoperative to the culture. If you can, frozen section or get agar, then after the agar, get to the gem. How you get the wound management in general, we can use on our ward everywhere. If there is wound drainage for 5 days, you get to vac. If it is continue after the vac, you go to DIR. If there is no, the vac is stopped the drainage, you can, after 2 weeks, remove the suture. Post-operatively, wound drainage, continuous 7 day, we can go to the surgery DIR. Within, of course, if you get the patient within the first 7 days and you can change the poly only, you have a high percent of success. And I think you manage to get rid from 2-stage reimplantation for the patient. What is the home message? Occlusive dressing, most, but not excessively, is needed. Don't change the dressing only if needed. Quick action if discharge is present. VAC, surgical action if drainage not controlled after 7 days. I present as used with one of the cases. 63 years old lady presented to us with severe pain and restriction of flexion and extension with inability of walking for more than 1 year. Her history belonged from suffering for severe osteoarthritic changes of the left knee, which is a cause for her TKR. If you observe, this is the patient presented like that, osteoarthritis. They did for her primary total knee replacement. And but the patient remains suffering from the pain and restriction of the movement and inability for walking. With the progressive of the X-ray, you see this varus cutting, and continuous there is some effusion. They think this is some sort of instability. They did for her another second surgery. I think there is patellar tendon rupture. That's why they put screw for her. If you observe the screw, maybe minor crack, I don't know, because there has flexion extension weak at that time. With the analysis of the failure, that the continuous is varus about 15 after the second surgery, after application of the screw. So it's a painful knee, as routinely we do ASR, CRP. ASR was serum 120, and CRP was positive, titer is 96. And also to prove this is the infection, we go to aspiration. Aspiration showed coagulase negative. And Staph aureus growth in with the sensitivity to the antibiotic, of course, with the agar and Brainhard. Agar 5 days, Brainhard tissue 15. as okay, this is infection, PJI, periprosthetic joint infection with the presence of the germ. As a definition, this is an infection. Two-stage reimplantation. We apply mobile spacer, new knee, poly, and bone cement. And there is a honey period, 2 to 3 months, according to the culture. Take the antibiotic, and after inflammatory markers, after 3 months or 2 months, getting down, the normalization, and all the swelling is going, and the patient moving this is the AP, and lateral as according to the principle and routine history for this infected. Thank you very much.
Thank you.
Now the microphone with you, Dr. Sina.
Thank you, Doctor. Thank you very much, sir. This is a wonderful lecture about the wound care and surgical wound care after any joint infection. So we are receiving now some questions. If you have, please, everyone can write in the chat to receive your questions. Well, I think I have one, sir. Can you hear me, Dr. Mahmoud?
Yes, with you. Go on.
Okay. I'm asking about if there is an infection after SSI, surgical site infection, and we are prepared for a DARE as a debridement and drainage. So can we stop the preoperative antibiotic before that in order to take culture and sensitivity from the knee joint?
Yes, Dr. San, thank you very much for this important questions. That's why when there is SSI or when there is discharge, that's why two things in international consensus, no change of direction, no swab, no antibiotic.
No antibiotic.
Is why? Because we want, and دائما اقول الملجأ مال العقرب رش عليه مي حتى يطلع. احنا نريد الجرثومه تطلع لنا. انتيبايوتيك يغطينا ما ينطينا، يسوي مثل انتيبايوما. ف please don't give antibiotic. This is يعني before 3 days she came for me a lady and all the markers ESR CRP is very high and she had restriction of the flexion extension and she had night pain. They gave him more than 60 injection of ميرونين 60 إبرة ميرونين marker. يعني yes, complication for the renal and without benefit. That's why whenever you suspect the infection, stop the antibiotic. Don't give antibiotic. بالعكس انت اسهل لك اذا ما ماخذ antibiotic aspiration synovial fluid دزل polymorph and white BC ويا الكلتشر and you prove this is infection or not. You are safe. تجمع النقاط definition بالdiagnosis 6 نقاط جمعت this is infection you deal it. لكن believe me antibiotic اللي دا يجون واللي دا نشوفه without benefit لمن اكو infection there is no role for the antibiotic. And please, you are my colleagues, whenever it's something is difficult, I say open the window, either deal it or refer it. We can manage it with pleasure.
Yes,
with pleasure.
Thank you, sir. So after that, if we are dealing with the total knee and we are going to have a DARE on the polyethylene exchange, you can give the pre-operative antibiotic 1 hour before, right?
Okay, this is not prophylaxis.
Yeah, not a prophylaxis.
Yes, يعني خلينا نميز بين البروفلاكسس
yes.
وبين احنا dealing with the case infection. هنا as general شو نسوي؟ ننطي له فينكومايسين على اساس يشتغل والمالتيبل اورجانيزم. احنا yes. بعدنا اورجانيزم ما نعرفه.
yes.
فنطي له فينكومايسين.
yes.
not على اساس انه هذه يشتغل على عده مايكرو اورجانيزم. نطي له اياه 5 days. ورا 5 days راح يطلع لك مال نتيجه الاجار.
تمام.
according to the guard, according to the gym, either you continue with the يعني شوف الsensitivity ماله, or you change to other antibiotic and give him for 6 weeks.
Exactly, sir.
6 weeks.
Okay. Another question here from Dr. Muhammad Asad. Any SSI developed to PJI, or is it certain for a certain percentage?
No, مو كل SSI surgical site infection cause PJI, but there is a strong relation. There is a strong relation. مثل ما بالبداية طلعت البحث، مو كل SSI ممكن يؤدي إلى surgical يعني ال PJI, but there is a strong relation. That's why we need يعني prevention from the SSI that not going to PJI.
Okay. Another question is that the role of a preoperative antibiotic. I think we have just said that, Dr. Haidar Jorani. We have just said that the preoperative antibiotics are not changed, but and you are asking about the type. Yes, Dr. Mahmood Shihab said that the vancomycin is the best choice for a preoperative only, not to treat the infection. Okay, Dr. Mustafa Al-Janabi said that you mentioned a watertight. Is there airtight suture, 3-layer skin suturing to prevent SSI, sir?
العفو ما فهمت سنان.
أستاذ ده يسأل الدكتور مصطفى الجنابي. You mentioned about a watertight suture. He's asking about an airtight suture, a 3-layer skin suturing to prevent surgical site infection.
3-layer? 3 شنو؟
3-layer suturing to prevent SSI.
يعني شنو قصده 3-layer؟ أنا ما
I think he meant by a multi-layer sutures. يعني نبدي احنا من
اي لا الكبسول نبدا من الكبسول. احنا قلنا الايديا بالكبسول ننطي السترينث الباور هذا والبايو بيردن حتى يتحمل، لانه فليكشن اكستنشن اكو بيها، البروفيوجن نحافظ عليها. ف بعدين نطلع على السبكوتينيوس وبعدين نطلع على السكين. المهم بيها انه لما تختار اختار نون ابزوربابل والديكسن. ليش؟ لو بالخط البياني شفتوها يتحمل السترينث مالتهم يتحمل فتره طويله، ولهذا انت لما خصوصا لما تيجي بالكبسول انت عندك فليكشن تندن من التندن اراوند ذا كبسول، هذه حاول تكون قويه. الديكسن اعتقد احنا او نون ابزوربابل هو اللي عندنا. أنا ما دخلت على تايب كان أكو بيها لأن الوقت ما يسمح لي، بس إحنا بالنسبة لنا الديكسون خيطوا بيها الكبسول والسبكتينيس بيها، وحتى السكين النايلون أو الديكسون، لأن هذول السترينث مالته فترة طويلة أحسن من السلك. هذا اللي ينطينا ووتر تايت سوتشرينج، لأنه شافوا إذا انجكشن تسوي ما يطلع. there is no drainage if you inject to the capsule. هسه احنا ترانزكزاميك اسيد بدنا نستعمله لما ووتر تايت سوتشر ما يطلع عندنا كلها بال inside the joint.
Yes, sir. Thank you, sir. Another question from Dr. Hussein Zaki. The color of discharge can give an idea or clue about wound in arthroplasty. He's asking about the discharge, if it is with colors or not.
Yes. مرات انت الكلر طبعا اذا بدك تنطي له انتي كواجلانت هذا يطلع مثل رماني الكلر ماله.
ممكن يكون هيموراجيك. يس.
بالضبط هيموراجيك. لهذا one of the احنا قلنا dealing of the medical management يعني بالدريسنج stop the anticoagulant لانه maybe anticoagulant هو مسوي السبب. لهذا لا مرات هي اذا باس ولو اني خلال الاكيوت فيز ما يلحق يسوي الباس، مرات اكو ديبريد يعني تشو وياها، هذه كلها ينطي لك فكره انه maybe there is infection and maybe not. بس انت مهم كل الميجرز اللي احنا قلناها له اول 48 ساعه اي مفروض هاي الشغلات ما تصير. اذا صارت هذا ما يعني انه انت تفتح، لا، احنا شرحنا الميثود اللي نقدر نسويها حتى لا نوصل انه this is persistent wound discharge. واحنا قلت لك احنا نخاف والله نيجي نشوف الضمات بيها شيء، لا، اول 48 ساعه لا تطخها، لا تطخها.
بالضبط.
my experience is 1 week and single antibiotic and everything is without infection.
Yes, thank you, sir. Dr. Mohsen Khalil is asking if we decide to go in a 2-session or 2-staged operation for established infection, for how long we can retain the spacer? Is it safe to retain it for a long period?
Yes. One thing, when the literature is said you can change the spacer وحكيناها يمكن if there is complication of the spacers affecting the neurovascular bundle or maceration of the skin getting outside, this is mandatory to change the exam. But if there is even dislodgement or dislocation but no urgent effect, you can keep it. First. Second, if you doing screening, routine screening after 3 weeks, 4 weeks, 1 month, 2 months, and there is still ESR, CRP marker, inflammatory marker is high without another cause with the other organs, you can change it. Till 3 times you can change the spacer and you do new debridement and with the new spacer.
Because that means in the first stage can be repeated more than 2 times, up to 3. Yes. Okay, thank you, sir. Dr. Ali Qasim, thank you, sir. If we choose to use a drains, is there any difference when using a single or 2 drain system?
احنا كنا the complication here drains very controversy about it, to use it or not use it. حقيقة إنه الاتجاه not use because يعني literature they يريدون إنه SSI، بس المشكلة قسم أكو من الجراحين they using tourniquet and not opening the tourniquet till the end suture and without drain. I think this is something it's very difficult because sometimes we know there is 3 sites of bleeding from the meniscus, lateral, medial, and the posterior capsule. So if it's coming and bleed and you're not putting drain, this may cause something, I don't know, hemoarthrosis and 9-year compression on the artery and nerve. And sometime when there is injury to the big vessels and you close the wound, this and you not detect this complication, the patient may need an amputation, an end amputation. وعندنا كيسات صايرة اخوان، فاني مو على شيء افضل افتح التورنيكا، سوي له لايجيشن وput the drain، بس الدرين سويها تمبونايت 6 ساعات وبعدين افتحها. فسكشن درينج احنا بدنا نحكي على 1 دكتور علي قاسم، فاذا 2 الريسك ماله يمكن اكثر. بس الانظر اللي يدافعون يقول انا اخلي وحده سوبرفيشال ما اريد دم، يعني حتى to be sure there is no hematoma، تخليه superficial the other deep and there is no hematoma. Still there is controversy about the usage of the section drain or not using. بس اللي يستخدم تورنيكا يفتح التورنيكا it's better to put 1 drain or 2 drain.
Yes. Dr. Saif Nabil is asking if there is any role of zinc and Mibo ointment for acceleration of the wound healing topically.
Mibo and شنو؟
And zinc ointment.
ماكو literature على هذا. الجلو اكو انه بس الميبو والهذه يعني كوميرشال بحوث ماكو عليه بالووند هيلينج، لان احنا اصلا ما نحتاج ميبو بها انتيبايوتيك اعتقد، ما نحتاج انتيبايوتيك. يعني كل هذا ما اريد اني انتيبايوتكس، ما اريد اورجانيزم، لانه الغايه from the start with the wound till last suture مثل ما شرحنا الحاله وراها انا ما اريد antibiotic. This is the only antibiotic I gave it to the pulling to the area. فماكو literature على هذا، فلهذا ما اقدر اجاوبك benefit or not.
Dr. Zaid, right? If we have a sign of surgical site infection, how do we know that we don't have periprosthetic joint infection? And if we are not sure, do we need change the polyethylene?
surgical site infecting يعني مثل superficial infection، يعني ماكو opening، فالdischarge ماله يكون قليل. ال PJI there is opening in the arthrotomy. فيصير prolong and copious discharge، مو مثل SSI. SSI مثل superficial infection. ولهذا أنا ليش أقول أول 48 ساعة لا تفتح الضمات ما يصير عندك SSI، لأنه الكومنست احنا قلنا 95% الفيرست يير الكومن هيماتوجينز 95% من سكين فلورا يجي، بس اذا الدريسنج مالك اوكلوزيف ما يجي، ما يصير سكين سايت انفكشن. ولهذا يختلف عن البي جي اي لما صار ريليشن وذ ذا امبلانت وذ ذا بروستيزيس راح يكون اوبننج بالارثروتومي، ديفيوز ديسشارج راح يصير، مو مثل سكين سايت انفكشن. لهذا ميديكال دريسنج او مودرن دريسنج ميبي فاك يفيدك بالاس اس اي.
وهو دائما استاذ يعني يقولون انه السيرجيكال سايت انفكشن not passing the dermal layer بينما البي جي اي when there is a periprosthetic infection and there is a sinus is started from the joint itself and goes upwards into the skin.
That's why I'm saying opening with the arthrotomy side to the joint.
Yes. Dr. Akram is asking about the patient is asked always the following question: when can I have to wash my knee in the bath? Can I have a bath?
ايه مو شاور، مو هذه مش مهم. لهذا انا اخذته من الاي سي ام. يعني احنا التراديشن ما يوصله،
صحيح،
لكن literature يقول after 48 hour you can get and not affecting the risk of the SSI, the risk of the PJI ولا affecting wound healing, but after 48 hour you can get shower. وهذه ينطي يعني اللي رايح برا البروتوكول مالهم ترى ورا 48 ساعه يقولوا روح خذ حمام. بس احنا لانه ناسنا تدري يخافون. بس after 48 hours go to the shower and this is proven by the documented by the ICM.
That هو some of surgeons, many of us, I mean, they use the tight seal wound closure after suturing. اكو هي اللزقات الجاهزه اللي تصير على الجروح. هذه ممكن انه any patient he has or she has her or his own bath freely after 2 days. يعني without affecting the wound.
انا استعمل كونفيل. كونفيل كلش هذا ما يعبر مي وهذا كله زين حتى يقدرون يغسلون. كونفيل زين لهم.
Don't have any questions here. So thank you for joining us. If you don't have questions or if you have it later, please write it here. This lecture, we are thankful for Dr. Mahmood Shihab for this informative lecture, and it will be done in the YouTube channel, my YouTube channel. So please, if you don't have my number, I will write it down here in the chat in order to anyone have a special group that I cannot reach it. You can have it. You can add me in the group, and then I will attach the channel of the YouTube to show every lectures has been proposed in the previous weeks. Tomorrow there will be the biomechanics of the knee at the same time at 9 p.m. Thank you very much, Dr. Mahmood Shihab. We are very pleased to meet you again. Thank you.
Thank you very much.
Thank you very much, sir.